Welcome, everybody. This is truly a unique time. It's an interesting platform, but I'm really glad that you could all take the time to join us today. I am Rebecca Dunsmore-Sue. I'm an OBGYN physician. I focus on gynecology and specifically on menopause and vulvovaginal specialties. And I am the medical director for Menopause at Swedish First Hill, and also medical director for Women's Wellness and GYN Specialty Services, which is a new clinic service line that we will be opening this year. And I really wanted to sort of have these seminars to sort of represent what we can do at Women's Wellness and Specialty GYN Services and the type of expertise that you can find there. I also am thrilled to announce that we have received a $250,000 gift to use as seed funding for this whole Women's Wellness Initiative. And we cannot do these innovative clinics and projects without private support. So I want to say thank you for that fantastic gift. I'm going to go over a little bit about how the call is going to go. We're going to talk first with our panelists and have them introduce themselves and ask a few questions that we get frequently in the clinic and also online. And then if you have questions, please use the Q&A button at the bottom of the Zoom. You can type your questions in there and we will definitely answer them during the second half of the call and be able to get to all of those questions then. But first, before we do anything else, I wanted to do a quick poll of the people on the call. So you should see a poll pop up in your Zoom screen. And we're going to ask you what is most impactful for you in perimenopause or menopause. And you can mark your answers on the screen. The selections are hot flashes, sleep problems, brain fog, or yes, all of these things are bothering me. And then we'll pull up the results to that poll in a few minutes. But first, I'm really excited to introduce Drs. Austin and Fuller. And Dr. Austin, why don't you start and tell us a little bit about yourself and how you got to this point in your career?
Sure. I'm Kristen Austin. I'm also OBGYN specialist at Swedish. And I started at Swedish in 2002, so been here a little while. I started as a generalist doing both obstetrics and gynecology, as many people in our specialty do. But over the years, I've slowly been transitioning to gynecology only, and I am loving it. It's where my passion truly is. I think that women deserve healthcare outside of just when we're pregnant and taking care of our babies, although that is also very important. Currently, I'm at Swedish Issaquah, and I do a fair amount of pelvic floor health there, including some urogynecology, but also take care of many women who have other menopause issues and premenopausal gynecologic issues as well. So I'm pleased to be here on this panel.
Thank you so much. And I also want to introduce Dr. Ashley Fuller. We actually live in the same office at Swedish First Hill. And I'd love, Ashley, if you can tell folks a little bit about how you ended up where you are.
Yeah. Well, thank you. I'm Ashley Fuller. Thank you for having me on this panel. It's exciting to be here talking about menopause. I have been a physician, OBGYN physician with Swedish/Minor and James at the beginning since 2010, so 10 years. I also was doing obstetrics and gynecology until about 2 years ago. I decided to make a big decision to transition to a gynecology-only practice. And I have chosen to kind of focus my gynecology-only practice on sexual health. So I see a lot of patients with sexual pain and low libido. Some of them are premenopausal, but a lot of them are postmenopausal. And I also focus on menopause and vulvovaginal disease. I chose these things because I find them both challenging to treat, but also really rewarding. I feel like as resident doctors, we didn't get a ton of training in these things. But I feel like, and I feel like in the past, when I had patients bring up some of these issues at some of their annuals, I sometimes felt like I wasn't really well equipped to handle or to help them with some of these issues because I didn't feel like I got the training in my residency. And I really try to focus on these things, as I know Dr. Dunsmore-Sue and Dr. Austin have also, to really help women because these are super common complaints. And they're not always easy things to treat, but when we do treat them successfully, which we definitely do, it is so rewarding for both for us as physicians, but also the patients to see them, kind of go through these transitions and kind of help make their life better. And I find it a really fun part of gynecology and patient care to be involved with.
Thank you. Well, I want to sort of follow up on that. I think often as OBGYNs, we hear that once a woman's childbearing years are done, she thinks she doesn't need us anymore. She no longer needs to see the OBGYN. She can just make her way with a primary care physician. Ashley, can you speak a little bit to why would you continue to see an OBGYN in years where you're not having babies?
Right. I think that's a great question. And I think it's a question that patients ask me a lot, especially now that women don't need pap smears every year. Like, do I need to come to my annual? Do I need to come every year? How often should I come? And I always tell patients that I'm happy to see patients as often as they want to be seen. I think it's important, even past childbearing years, to have a gynecologist. And part of that is because, sometimes birth control, but especially, since we're talking about menopause here, I think that we as society don't prepare women very well for what's going to happen to their bodies in menopause. And it's not something that's talked about too much except for within friend groups. And women's experiences are very varied. Some people have very easy transitions to menopause. Some women have very difficult transitions and have a lot of bothersome symptoms. And so I feel like when you see a gynecologist kind of ongoing and you already have a relationship with them, then you can kind of continue as things kind of come up and as you go through your transition to menopause, or if you're already in menopause, you have someone you can talk to about some of these symptoms, and someone that is knowledgeable in these kinds of things. So I do think it's important, even after childbearing years, to have someone that's knowledgeable in those areas and as a gynecologist.
Excellent. Kristen, we talk a lot about hot flashes when we talk about menopause. It's the thing you hear the most about. But there are tons of other symptoms that come up, and actually this is probably a good time to bring up the results of that poll, Shiloh, if you can, and show us sort of what at least people on the call felt. So as you can see, even on this call, hot flashes are there, but sleep problems and brain fog and all of the above, all of the above wins out, of course. So what are the most common things that bring women into your office?
I think that's a great poll, and I think all of the above, and there probably could have been an other that may have been even even more, because it's truly a whole myriad of things that bring people into the office. I think one thing that we're learning more as more and more focus is being paid attention to the menopause years is that this whole perimenopause is also a really long period of time, or it can be long, and that's actually a time of people's lives that we get a lot of questions. One of the things that happens often in this perimenopause, when you're not quite in menopause yet, but you're almost there, is just a lot of fluctuation in hormones, and that can lead to all kinds of different mood symptoms. So we have a lot of patients who come in and just have some mood symptoms that they want to go over. Also bleeding problems. Even when you're postmenopausal, sometimes people will have occasional random bleeding, and that can be really scary because people think, the worst. But there's a lot of things that can actually be explained by normal, not cancer types of situations. Mm-hmm. So some irregular bleeding. And then I work, as I mentioned earlier, a lot with women in the pelvic floor area, which means sometimes people will come in and say, I was jumping on the trampoline with my, grandkids, and all of a sudden, oh my gosh, that's never happened before. I'm like leaking urine or something like that. And that can happen a little bit more with women in menopause. They might be like urine or something like that, or just feeling just pressure, or just general pelvic health issues. A lot of women are still, very active, of course, in our menopause years, whether or not that's athletically active, or we're still, intimately involved with our partners when having sexual relations, and sometimes that also becomes discomfortable. I mean, it's not comfortable, and so many women come to me just because they're having discomfort with sexual relations, and that's new. So there's a whole myriad of reasons why people come in, other than just straight old hot flashes.
That's an excellent transition. I was going to say we hear a lot about urinary changes as we transition into menopause, whether it be incontinence or other issues. How do we as Kristen, can you talk a little bit about how we as gynecologists can help women to work through these issues and solve them?
Yeah, well, I think something that all three of us have kind of mentioned is that we realized as we were in our careers that we didn't necessarily have a ton of training in this menopause time. And I think one of the things as gynecologists that we do is we sit down and we just really listen to what our patients are experiencing. And in the urinary health area, it can be, straightforward, I'm leaking urine, but it can also be just like prolapse, or your bladder might be sagging a little bit, the saggy vagina. So a lot of what we do is really just try to help diagnose the problem, because it could be, you might have a number of things that are contributing to this feeling of discomfort. It could be that your bladder is sagging. It could be you're having more difficulty having, bowel movements. It could be that you just feel this weight, and that's actually that your uterus is kind of sagging, different type of prolapse, or it could be straight urinary incontinence. And then there's different types of urinary incontinence. And so we can really listen to you and try to figure out with you what it is exactly that is bothering you, and then go over a whole host of things that we can do to help. We are surgeons, but we're also medically trained. And so we have both at our disposal, not just surgical options, but we have non-surgical options. And so it might be something as simple as learning some exercises. There's medications that we can use. There's pelvic floor physical therapy. There's a whole pelvic floor physical therapy is kind of a new specialty within physical therapy that has really helped women a lot. And many women who start to do pelvic floor physical therapy don't need to do anything in addition to that. It's been really helpful to help fix a lot of those problems.
Excellent. So Ashley, you and I see a lot in our clinic of women who come in and say their libido has changed in the transition into menopause. And it's a huge concern for women. What are some of the causes you see, and how do you help with this?
I think that's a great question. I think that libido is a big concern. I think I see it for women in general, but definitely in perimenopausal and menopausal women. In my menopausal women, I think I see a lot of low libido due to pain with sex, and Kristen kind of alluded to that too. None of us want to do something that's painful. One of the things that changes with our hormones when our estrogen is low, or one of the effects of hormones, is that our vaginas get tighter and drier with lower estrogen levels. And so when that starts happening, women sometimes start having pain with sex. And then they often stop having sex because it's painful, which makes sense. And then they sometimes go a while, and then they come in to see me and tell me, well, I just don't really want to have sex. And when you really ask them, it really has a lot to do with pain. And so I don't think anyone should want to do something that's painful for them. So I work with these women on how to get the vaginal tissues to be healthier. Often with vaginal estrogen helps the vaginal mucosa stretch better and also self-moisturize better, and can make sex less painful and hopefully more enjoyable. That often makes a huge difference. Sometimes if it's been a while since the patient's been able to have penetrative sex, dilators or pelvic floor physical therapy is also very helpful. I think there is some component of if you don't use it, you lose it a little bit, especially with postmenopausal sex. I definitely have patients that come in and are having regular sex and are not having problems. And so I encourage patients to continue, if they are having good sex in their menopausal years, to continue doing it. Because I do think getting more blood flow to the area, stretching those tissues is really, really helpful. But libido in general is a bigger, it's not just pain, there are other issues. So hormonal issues, I always say women's libido is just more complicated than men's libido. It's not an on and off switch. It has to do with how we feel about our day, how we feel about our relationship with our partner, how we feel about our bodies, how much sleep we got last night. It's multifactorial. And so I think when you're going through the throes of perimenopause, where your emotions and your hormones are ups and downs, and you're exhausted, it's not always a time when sex is a high priority on your list. And so I think that there are definitely different ways to look at it and different ways to kind of non-medical ways to try to kind of optimize energy levels and interest in sex. But it's definitely not always an easy fix, but it's definitely something I work with patients on, and definitely something that is treatable.
And to follow up on that, you talked a little bit about vaginal hormone, but there are lots of hormones that we use. It's basically a mainstay in treating menopause, replacing the hormones that have gone away as the ovaries fail. Mm-hmm. What types of hormone do you typically use, and why do you use those types?
Right. So a lot of the mainstays of treating menopausal symptoms are hormones. There are other options, but specifically with hormones, we look at what the ovaries are no longer making, which is mostly estrogen and progesterone. So there's different ways that we use hormones. People often use a term called bioidentical, and that is really a marketing term that is basically telling you that these hormones are the same as what your body would produce. They are often very high quality hormones, and I do prescribe a lot of bioidentical hormones. There is an idea that they are safer and that they are don't have the same risks, or that they are more natural, and that is not necessarily true. There's two ways you can get bioidentical hormones. They can be FDA approved hormones, estrogens that come in patch or pill or gel form, and oral progesterones. That is what I prescribe and most of us prescribe. I prefer FDA approved hormones because at any point you can pull that medication off the manufacturing line and know almost exactly how much hormone is in that product. So that means it's safer for you. The other way bioidentical hormones are made is compounded. So that means a compounding pharmacist, the pharmacy, is making a specific batch of that hormone just for you. And while it may sound ideal that it's made just for you, they're making such a small batch that there's going to be a large variation in how much hormone you're actually getting. So you could have a product that's actually has less effectiveness for you, but also a product that could actually harm you more because it could have too much hormone. So, but generally the hormones we prescribe are going to be estrogen and progesterones, and they're going to be FDA approved, but they may also be bioidentical, which has the same risks, but a lot of patients like that idea because they seem to be more natural.
Thank you so much for making that distinction, because I think you and I talk about this a lot in clinic with our patients about, what is marketing and what is reality in terms of hormone replacement. And I know our goal, and I'm sure Kristen's is as well, is really safety above all. If you're going to use hormone, using it safely is key. Right. Kristen, if a woman can't use hormones, what other strategies and medications do we sometimes use to help her?
Yeah, well, like Ashley Fuller, Dr. Fuller was mentioning, we see patients for, vaginal pain or pain with intercourse and whatnot. And other than estrogen, one of my favorites is actually using some natural oils if a woman is not able to take estrogen, for example. So I recommend a lot of women use coconut oil, actually, as not just a lubricant really for intercourse, but actually is more of a maintenance. Our vaginal area is its skin. And just like we want to, take care of our skin elsewhere on our body, I think the vaginal skin deserves a little maintenance as well. So, but anyway, I think coconut oil works really well. So I had a woman the other day who was allergic to coconut, so I recommended trying all of it. So some of the natural oils I think actually work fairly well. And I've had a number of patients who are not able to take hormones have really good success with that. Other reasons we use hormones could be for hot flashes, for example. And there are some medications that are not hormones that will help hot flashes. There's some of the antidepressants actually work really well for hot flashes. We're not using the antidepressants because you're depressed. We're using them because they actually do help with hot flashes. If you, for example, have really bad night sweats, a lot of women come in and they're just like, I am saturating the sheets at night. It's terrible. There's some medications that help more, maybe for night sweats, such as gabapentin. There's even a blood pressure medication that helps a lot with hot flashes and night sweats. So there are other options out there other than, hormones for those women who can't take I think the most important thing is really everyone is really different, and everyone's experiencing menopause a little bit of a different way. And so we are going to listen and figure out a plan together, figure out what it is that is bothering you the most, and then address that. I think in the past, what we used to do was just throw hormones at everyone, and we didn't do such a good job at distinguishing, what is your particular concern. And instead, we kind of had a one-size-fits-all treatment approach. But over the years, I think we've gotten a lot better at really figuring out what it is that you need and addressing that individually. Then I guess there's also like totally non-medical strategies too that we can talk to. The cooling pillow at night, wristbands that are cool that will help. So completely non-medical options are out there as well.
And I know I often counsel on like lifestyle interventions and diet and alcohol use and all those things as well, which can contribute. And, we struggle as physicians to talk about things like herbals or acupuncture, things like that, where there's not the type of data that we like to see in order to tell someone that something's successful. But, those options are there and are things we can at least talk about with you and talk about what's safe and not safe to try. I want to throw up another poll as we move into the Q&A because I see some questions popping up there. But there's another poll, and this one I just want to hear from folks about how they felt. If you've gone to the doctor's office and asked about menopause symptoms, how did you feel that went? Did you feel heard? Did you feel dismissed? I've heard many women come into my office and say, they just told me to suck it up. You felt heard, but they really didn't have any answers, or you didn't even know you could ask a doctor about this. And we'll look at the answers in a couple of minutes. We'll give you a chance to answer those questions. But to follow on with the last question, we have a question in the Q&A, which is, what are some reasons a woman couldn't use hormones? And the other side of that is that someone else has asked, well, if you have a family history of breast cancer, can you not use hormone replacement? Which is a pretty complicated question, one I think we can address. Do you want to start, Ashley, and then Kristen, I'm going to have you chime in as well.
Sure. So some reasons women shouldn't be on hormones. So women who've had a history of a blood clot, so hormones are going to increase your risk of blood clots, specifically estrogen does this. So if you ever had a DVT or deep vein thrombosis or a pulmonary embolus in the past, this is a reason not to take hormones. Women who smoke cigarettes should also not use hormones, and that's because it increases your risks of having a blood clot. When I start a woman on hormones, I actually always talk through some of the studies that have been done about hormones, because I think it's important to know why our pendulum has swung so far from being very anti-hormone in the 2000s to being, I think, moving toward being more pro-hormone. And so if you pick up a box of estrogen, it's going to tell you, the FDA nicely warns you about your cardiovascular risk and breast cancer risk from that medicine. And so I would normally, I feel like the FDA wants me to tell you that cardiovascular risks are a big problem with estrogen, but it's actually not really true. We think that when you start estrogen at a young age around the time of your menopause and you stay on estrogen, we actually think it's probably somewhat cardioprotective for you. So sometimes patients do have cardiovascular risks that I think aren't appropriate for them to have be on hormones, like uncontrolled hypertension or things like that. But for the most part, for healthy women around the time of menopause, starting on estrogen probably, we think, keeps them from building up plaques in their arteries, and they may prevent some cardiovascular disease, which is not what we initially thought from certain studies done in the early 2000s. Do you want to talk about breast cancer, Kristen, or I can, but you go ahead.
Sure. The other thing I was thinking of is that, a lot of those original studies were done with oral hormones, and there's been some subsequent studies just showing that when women get their hormones transdermally, in other words, it's a cream or it's like a vaginal insert or a patch, when you're absorbing it through the skin, they found that a lot of those risks are much less than they were when a lot of those studies were done. And so I also talk to people about like the individual studies, like Dr. Fuller was saying, and say, okay, well, yes, this study showed this, but there's these other studies, and also what are your particular risks? So like maybe you're someone who doesn't have any cardiovascular history, disease history in your family. Your cholesterol is good. You don't have high blood pressure. For you, the risk of hormone, like taking hormones, may be like minuscule compared to the benefit that you're going to get from them. So it's really an individual approach. And that goes really right into breast cancer. So breast cancers are not all the same either. Some breast cancers are estrogen receptor positive, meaning they are going to respond to estrogen. And those are the women that we want to minimize estrogen, extra estrogen. But even, or progesterone receptor positive. So we not only use estrogen, we're also using progesterone. So we're going to look at the individual breast cancer itself and see, is this a breast cancer that is more at risk or less at risk with taking estrogen and progesterone? And then, I do have a number of women who have breast cancer and are still taking a little bit of hormone because, again, we kind of like look at the overall picture. And sometimes just a little bit of hormone is all they need. So it's not like an absolute, no, you can't take it. We kind of work, usually, and if that's the case, I'm going to work together with my patient's oncologist and come up with a plan together to figure out what is best for you. And then just speaking of progesterone, that was one of the other things I was going to think of is that, we talked a lot about estrogen, but there's this other hormone, progesterone too. And some of those studies that Ashley or Dr. Fuller was mentioning kind of make progesterone maybe more of the culprit as far as the concerns. So I don't know if you wanted to jump in on that too.
I was going to jump in and say that, I agree with the progesterone comment. That's all basically out of the Women's Health Initiative study, which I know a lot of people have heard about. But there are a lot of issues with that study. But also it's a progesterone we don't tend to use anymore. Right. And actually, what I do tell my patients is that there's a lovely population-based study out of France where they looked at women taking the one that we tend to use, micronized progesterone, and those women did not have an increased risk of breast cancer. Right. When I'm talking to my patients, I just say, 1 in 8 women is going to have breast cancer. So most of us will have some family history, and family history alone is not a contraindication to using hormone. It's a reason for a conversation. And the last point I always like to make about breast cancer is, there are two other points. I'm going to talk a lot now. One point is that, breast cancer isn't what kills us as women. What kills us is cardiovascular disease and complications of bone fractures, specifically hip fractures. So while breast cancer is scary and we need to think about it, and as women it's a tough thing to go through, it's not the thing that's going to kill us. So we need to be balancing risks and benefits of hormone. I had another point which has left me because I'm having brain fog. So I'm just going to move on to another question. If it comes to me, I'll make it for you. You've been asked to speak a little bit to menopause and anxiety. Kristen, do you want to launch into that one first?
Sure. Menopause and anxiety. I feel like just right now, this anxiety is something we all have. Yes. But it's been a tough time. And so sometimes it is a little bit challenging to figure out what is the relationship between menopause and anxiety. But often we'll look at, I find this is more an issue in kind of the perimenopause period of time where you are still making some hormone, but sometimes your hormones are high and sometimes they're low, and it's just this kind of like you're in constant flux, really. And I think a lot of women react to that change in the hormone. So if that's the case, sometimes we try to kind of level things out. And it might be just taking something continuously that is gonna level things out. But again, how we get there is by really putting all the clues together, trying to figure out, okay, so when is it that you're more anxious? When is it that you feel better? And again, putting the whole picture together.
Excellent. I'll throw one at Ashley. Someone asked, I've never taken anything. I'm 61 now, and vaginal dryness is definitely a problem. Is it okay to treat it at this point?
Definitely. You can always treat vaginal dryness and with vaginal estrogen or with some of the things Dr. Austin was talking about with coconut oil and vaginal moisturizers. But, you know, when we talk about oral hormones or systemic hormones, we don't like to start them too long after you've been in menopause. That's actually what the Women's Health Initiative kind of taught us, that women who spend time not being on hormones probably are building up plaques in their arteries. And then when we start them on estrogen could increase their cardiovascular risk. So someone in their 60s who's been in menopause for a while is not someone I would love to start on systemic estrogen, but vaginal estrogen does not have the same risks as systemic estrogen. So it does not increase your risk of breast cancer or cardiovascular disease. And there are a couple of different preparations of vaginal estrogen, and I usually talk through with patients what those preparations are and how they're all different a little bit and what benefits they could see from it. But if patients are having, or you know, if you're having pain with sex or feeling dryness, I think vaginal estrogen is such a great product, and I think it's very, very safe. And I highly encourage patients to talk to their gynecologist or provider about it.
Excellent. Kristen, is there a typical timeline for women as they enter and go through menopause?
No.
That was easy.
I don't know if you guys saw this study recently, I think it was last year, that there was some more documentation really showing us that that period of time in which a woman can go through the perimenopause to menopause is more like 10 years, not like the 1 to 2 years that I think a lot of us were taught 20 years ago. And so I think, yeah, it can be 1 year, it can be 10 years.
Yeah.
It varies.
Agreed. And that leads into another question. But before we get there, I wanted to pull up the results of the poll because everybody so kindly took it. We should find out how people felt they were heard. Lots of people were heard but didn't have any solutions. Well, that's why we're here today and why we want to talk about menopause and the fact that there are those of us out here who really do have solutions that can be talked about. So thank you so much for taking that poll. Next question that popped up in the Q&A, which I think is a great one, may also not have a great answer, is why do some women have more severe symptoms than others? I'm going to throw it back at Kristen just because you took the last one so well. I'm going to give you all the hard questions.
Do we have an answer for that? If you have an answer for that, I'm willing to hear why. I don't know why.
Because that's really don't.
No, I don't know.
Really don't know, and it's so variable, isn't it?
You know, it's all over the place. Like some women, yes, right.
Some women go through menopause, never a hot flash, never a symptom. Their mood is even. Their libido is great.
Yeah.
You know, some women have hot flashes for 5 years before their periods even get irregular. You know, we really don't know.
No.
And some of that is research. We just haven't done it. And some of it, it's just hard. Every woman responds differently to her own hormones as well as outside. Ashley, out of all the options, patch, vaginal insert, pills, what's most effective?
Well, I think what's most effective is what makes you feel better. And so it's different for everyone, right? So most vaginal estrogen preparations are not going to treat hot flashes and night sweats and some of like the more systemic issues of menopause. They're really just for vaginal dryness, although there is one ring that is actually a systemic estrogen, but most vaginal inserts are not going to do that. Patches, I think we all kind of prefer patches because we think that transdermal estrogen, whether it's a gel or a patch, it doesn't have the same blood clot risk as we were talking about before. So when I start someone on estrogen, I usually start with a patch. Now, definitely there are patients that say, oh, my skin's very sensitive. Like I know I'm going to have, irritation from the adhesive. And so if they don't have another contraindication to being on an oral medicine, then we definitely can do that. But the patch is pretty nice. It gives you a nice even distribution of the hormones. You're not just taking a pill every day and kind of getting a spike in your estrogen. It's pretty even, and it's a nice way to use estrogen. But again, it's really about the patient. If some patients don't tolerate oral very well, I have a couple patients on gels because the patch didn't work very well for them because of the adhesive, and they really like some of the FDA approved gels. So there's options, which I think is great because then we can kind of find what works best for you.
Does either of you want to take the next question? Because it's a little bit of a tough one. Menopause and hair loss. Nobody's jumping up.
I mean, I think hormones
Yeah.
can be part of that. I don't think we know exactly. I mean, obviously it's important to rule out other things like thyroid disease and low ferritin levels, things like that. But I definitely something that we see. And my guess is a portion of it's genetic, and maybe not be something that is super easy to alter. You know, but I do think some of it could definitely be hormonal. My best answer is that I don't really know, but I definitely do see patients with this complaint sometimes.
Yeah, I
Thanks
often
for taking that.
I often also talk a little bit about, diet
Yeah.
interventions, including upping your iron, taking biotin,
Yeah.
and there's some other
Yes.
supplements that can be
Yes.
helpful. The other thing I always try to ask women who are having hair loss issues is, have you been taking something that I haven't prescribed, like testosterone? So
Yes.
testosterone is not a hormone that we need to replace in most women in menopause. Your ovaries continue to make it through your menopause at the levels that they were making it before. But we see a lot of people from outside clinics getting put on testosterone, and that can give you male pattern balding.
Yes.
The higher your testosterone goes, the more likely you are to go bald.
Right.
Last thing I wanted to throw out there, it's not a Q&A, but Kristen, can you speak a little bit about bone health in menopause, and why is it important, and how do hormones help there?
Yeah, well, I think you mentioned that the bone fractures, and hip fractures are one of the leading causes or can cause other problems that actually can be a cause of mortality. So bone health is really important. We do actually, I don't, we do have a bone health clinic also with specialists who specialize in bone health. And I personally work a lot in conjunction with our bone health clinic here at Swedish. But why is it important? So it's important because a lot of women have that problem of the osteoporosis and thinning of the bone, increased risk for fracture. Estrogen is considered, a treatment for that to prevent osteoporosis. And so that is one thing I definitely bring into the conversation too when we're talking about the overall health of someone is, bone loss something that is a concern, and have you actually been tested for it? It's important, I think, for women in a menopause to be screened for osteoporosis. The standard recommendation is to be screened when you're in menopause and then about every 10 years. I don't know if the two of you do things differently, but feel free to jump in. There's also other non-hormonal options to treat osteoporosis too.
Yeah, I mean that's basically how I approach it. I'm pretty sure that's how Ashley does too.
Yes.
It's something that we have to think about. It's something that may not be as apparent or as front of your mind as you're going through menopause, but that's a time to think about it and talk about it, because if you want to start hormones, it's best to start them at the transition into menopause, and they could protect your bones later on. Whereas we may not see the osteoporosis until you're in your 60s or even your 70s, and that's where it causes problems.
Yeah, I think we should continue throughout our lives to, get plenty of calcium and vitamin D. And I think we tend to have our maximum, like our best bone quality is in our early 30s. So if you have some younger women in your lives out there, make sure that they're getting their calcium and their vitamin D as well.
Excellent. I am going to sort of, I don't think I see any more Q&A. I'm just going to check it really quickly. Nope, no more open questions for us. So I would like to sort of move on now and sort of head towards the end of this call. I wanted to ask if either of you have any concluding thoughts or anything else that you wanted to add. Ashley, why don't you start out?
I would just say that, I think that, we've kind of touched on this, but everyone's different. How they go through their perimenopause and menopause is different. The things that are concerning them the most are going to be different. And, I think a lot of women get their information about this from their friends because that's who they have to talk about this. And every woman's individual experience is so different that if you're having issues, please reach out. I mean, we are here to help women with these things. We see a lot of this. There are things that can be helpful. If you are, suffering with any of these concerns, or even if you just want more information, please reach out. I really try to encourage women to find a really reputable source of information to find their information, because on the internet you can kind of go down the rabbit hole of finding not great information. And so encourage you to find good sources of information or reach out to our clinics for help with these kind of issues, and support other women. I mean, I think we, as women go through this, it's great to have friends and support. Just remember that we're all in this together, kind of thing, and it's good to have other strong females in your life to help you through things like this.
Kristen, any concluding thoughts?
I mean, I agree with all of that. Of course, that everyone is individual, and we need to approach things, for you. One of the other things too is that we're going to work through this together. This is not usually, well, sometimes we're lucky and we find a solution right away, but oftentimes these are things that we're going to kind of figure out what's best for you. And it's a process. So it may be revisiting the whatever the concern is a few times before we kind of get it right. But menopause is a process, and basically we are here to try to help you get through it as best we can.
Excellent.
Not get through it. We embrace it.
Yeah. I wanted to mention that we have 2 other webinars coming up. We are going to do a webinar specifically focusing on cardiovascular and heart health for women, and that's October 13th at noon. And then we are going to do one just more generally on healthy aging, and sort of more holistic approach to healthy aging, and that's on November 17th at noon. And I wanted to say that part of building this women's wellness and GYN specialty services is to connect all these wonderful providers that we have already at Swedish doing this work. And that's why I wanted to focus on the fact that Dr. Austin is out at Disqua. And so if you're an East Side person and want to see her, she's there. We're here at First Hill. We'll hopefully expand into Ballard as well, so that we have a sort of a wraparound program for women, because we want to treat them in a very holistic manner. I want to thank everyone who joined us on this webinar. Thank our physicians especially. Thank our attendees. There will be a survey/evaluation that'll sort of head out to you after we're done. So definitely keep a lookout for that. And if you have any further questions about the program, about the clinic, any of those things, please email Lorna Neeland. I'm not sure if she can pull up the attached slide, but her email is lorna.neeland, that's Kneeland, at swedish.org. Or you can, get in touch with the foundation where you signed up for this webinar. So thank you, everyone, and we will see you next month at noon.